Okay, I think I can jump in here. People are joining a little at a time. So thank you for joining us today. I just want to take a moment to ensure that everyone in the audience is ready and comfortable with the technical aspects of the webinar. As you see, closed captioning is available, and we also have American Sign Language capabilities enabled for this meeting. You can activate it by clicking the interpretation icon on your Zoom navigation bar. If you need tech support during the webinar, please send a chat message to the hosts and we will address it for you. Lastly, if you have questions during the presentation, please enter them into the Q&A area. The questions will be sent directly to the presenters and moderators, and we'll either address them in real time or we'll hold them until the Q&A session at the end. Next slide, please. I just want to note that the views expressed in written conference materials or publications and by speakers or moderators don't necessarily reflect the official policies of the U.S. Department of Health and Human Services and Substance Abuse and Mental Health Services Administration, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Next slide, please. Today's webinar is hosted by SAMHSA's 988 Crisis Systems Response TTAC. SAMHSA has selected Altarum to provide training and technical assistance support to states, territories, tribal organizations, and community partners across the 988 Suicide and Crisis Lifeline and Continuum of Care, along with our partners W2 Consulting Corporation and Change Matrix LLC, who have extensive experience with crisis services and technical assistance. The TTAC was formed to support the continued growth of the 988 Lifeline and build a more robust crisis care system. The goal of the TTAC is to support a crisis system that's integrated, sustainable, and aligned with evidence-based and evidence-informed practice. We'll drop the link where you can contact the TTAC for further questions or any technical assistance needs. Next slide. I'd like to thank the team at SAMHSA for supporting these efforts. So thanks to Jill Mays, Division Director of Crisis System Transformation, and China Locklear, Public Health Advisor at SAMHSA, for leading these efforts for the older adult work stream. Next slide. Today's webinar will focus on the role of tribal elders and older adults and how they can play an integral role in the crisis system and highlight a strategy for integrating these groups into the crisis continuum through options like formal programs at the state level or more informal community-based programs. Participants will learn crisis and behavioral health systems, how they can intentionally integrate tribal elders and older adults into systems design and service delivery, highlighting practical strategies, training pathways, and real-world examples that leverage their strengths in prevention, crisis response, care navigation, and recovery efforts. Next slide, please. So here's the agenda. We're going to spend a few minutes on the introduction and housekeeping, and then we'll transition to talk about examples of tribal elders in the crisis continuum. And then I'll pass it off to my colleagues at the Pennsylvania Certified Elder Adult Peer Support Specialist Program. We'll hear from a colleague in Massachusetts about the COPES expansion efforts, and then we'll hear from a certified older adult peer specialist about their experience in action. And then, like I said, we'll reserve a few minutes at the end for Q&A. Next slide, please. If you can take a minute and just answer this poll, it's helpful to know who's in our audience. So go ahead and if you have time to say what pillar of the crisis system do you work in and what is your role? If none of these options exactly match, just pick the best option. So we'll give you about 30 seconds to do this. Okay, let's see. Looks like the majority of our audience are from crisis call centers, followed by mobile crisis teams, and stabilization. We have a pretty good mix actually across the pillars. And then we have program managers, some state leadership, social workers, crisis workers, kind of split across that, both options. Great, thank you so much for responding to that. Next slide, please. Great. So I'm just going to introduce our speakers. So the first speaker will be myself. I'm a project manager at Altarum, and we support through the TTAC states, tribal organizations, and community partners in strengthening behavioral health and crisis systems, with a focus on integrating aging, long-term services, and culturally responsive approaches across the continuum. I'm also a member of the tribal work stream for the TTAC, and I work with tribes across the country to support their needs in improving their crisis system. Next slide, please. Dr. Jameson is an assistant professor of psychiatry at the University of Pennsylvania and co-leader of the Certified Older Adult Peer Specialist program, specializing in peer-to-peer and family peer support models in behavioral health. Next slide, please. Rob Walker is a certified peer specialist and certified older adult peer specialist who serves as an external consumer engagement liaison at the Massachusetts Department of Mental Health. Next slide, please. And we have Jim Klassen, who's a certified older adult peer specialist trainer and advanced RAP facilitator with more than 35 years of workforce development experience and lived experience in recovery-oriented peer support. And next slide, please. Great, thank you. So we'll jump into our presentations. The first section of this workshop is about hardwiring elder and knowledge keeper roles into crisis systems. So engagement with elders isn't dependent on a single relationship or a single champion, but is built into protocols, staffing models, and standard workflows. So for those of you doing direct service, mobile crisis, outpatient peer support, suicide prevention, we have a good mix today. Think of hardwiring as creating reliable touch points where an elder or cultural advisor can support prevention, de-escalation, decision-making, and follow-up care. So the goal is not to replace clinical care, but to strengthen the system's ability to create trust, continuity, and cultural fits across the continuum. Hardwiring also helps reduce avoidable recrisis by improving connection to community supports after the immediate risk has passed. Next slide, please. So in many communities, an elder is not simply an older adult. It's a role bestowed by the community based on spiritual and cultural knowledge, responsibility, and leadership. Knowledge keepers are entrusted with teachings and are often trained through years of mentorship on what can be shared and what must be protected. Clinically, this matters because elders can serve as protective factors in a lot of communities, strengthening connections, identity, and trust, often helping people move from I won't engage, I don't want to engage, to I'll try and take the next step. Implementation-wise, it means we should not improvise these roles. We should define them clearly, what the elder is invited to do, what are the boundaries and expectations, and how the clinical team coordinates with them respectively. Next slide, please. Being a good neighbor approach is fundamentally relational. So that means inviting elders early, following local protocols, and prioritizing reciprocity. And this might include appropriate cultural gifts that are expectations, and making sure the elder is supported before, during, and after their involvement. Practical steps include having a clear point of contact, preparing elders with the context and agenda, ensuring accessibility and support needs are met. And for knowledge keepers specifically, a core principle is knowledge governance, they determine what can be shared, when, and how. So the system's job is to plan with elders, not for them. Next slide, please. Okay, so hardwiring in this sense means naming where elders or cultural advisors are brought in, like points of triage, safety planning, law enforcement diversion programs, discharge planning, post-crisis follow-up, while protecting consent and boundaries on what is documented and what is shared. Implementation guidance also emphasizes that traditional healing communities retain cultural authority over their practices and knowledge, including in ensuring that safeguards are in place to prevent appropriation. Clinically, that supports safer care. Operationally, it reduces variabilities across shifts and settings for workforce. Next slide, please. There are several policy models that exist that you can directly apply to several programs. The Indian Health Service Community Crisis Response Guidance encourages communities to identify and enlist local tribal resources as part of a tailored response rather than applying a one-size-fits-all approach. So in Washington State, tribal coordination templates provide practical structure for documenting contacts, roles, and handoff procedures that can be adapted to include elders, thereby reducing the risk of handoffs and improving the process. Next slide, please. Implementation gets easier when you use administrative tools that translate these values that we're talking about into existing workflows. For example, SAMHSA's Tip 61 includes a tribal practice approval form that helps programs document traditional practices using community-defined criteria, like longevity, teachings and value alignment, elder approval, and really importantly, community feedback. On the financing side, California's Medi-Cal guidance illustrates how Medicaid policy can explicitly cover traditional services, things like traditional healers and natural helper services. These things together offer a roadmap for sustainable reimbursement. Next slide, please. One workforce example is the Northwest Portland Area Indian Health Board's behavioral health aid pathway, which pairs academic training with community mentorship. The behavioral health aid scope includes culturally grounded wellness promotion, trauma-informed crisis counseling, and psychospiritual support. And certification emphasizes supervised practice and cultural implementation, reinforcing that cultural knowledge isn't supplemental, but it's a core workforce competency. Next slide, please. So in day-to-day practice, behavioral health aides function as counselors, educators, healthcare and service advocates, amongst other roles as well. At the foundational level, they deliver community wellness activities like talking circles, cultural practices, alongside screening, referral, case management, and crisis counseling. More advanced levels might expand into substance use assessment and family interventions as well. The key takeaways is that this model is community embedded, culturally relevant, and scalable through structured supervision, and importantly, certification. Next slide, please. The University of Alaska Fairbanks Rural Human Services Certificate is another example of a workforce model that's especially relevant for rural settings. The program, which has served rural Alaska since the 1970s, uses a cohort-based format and week-long intensives and integrates Alaska Native values and learning styles, with elders a core part of the instructional team. The curriculum covers crisis-relevant competencies like suicide prevention, crisis intervention, grief and healing, substance use counseling, interpersonal violence, amongst others, showing how to build capacity and capabilities while honoring Indigenous pedagogy. Next slide, please. So to close, we've gathered a few practical steps that you can take to apply these learnings to your own programming. So first, it's really important to name these roles in an org chart, MOUs, or protocols. That way you can start to understand sustainable funding sources and really hardwire these into your organization. Second, using existing tribal or state or county coordination protocols to clarify who is contacted during a crisis, how consent-based information sharing actually happens, the do's and don'ts, and how to follow up and coordinate care, especially across 988 mobile crisis and tribal providers. Third, aligning with examples of existing workforce pathways. So we've given examples like the behavioral health aid program, additionally community responders or peer specialist models that we'll talk about next. These programs formalize culturally grounded helping roles with training, supervision, and clearly outlining a scope of practice for these roles. Next, strengthening continuity of care by mapping warm handoffs from crisis identification through aftercare and explicitly building in natural helpers, peers, and traditional support so people don't disengage after they've had an acute experience. So transitions are where risk often increases. And lastly, ensure all of this work is grounded in respect for Indigenous knowledge, sovereignty, and consent, including clarity about what can be shared, what must be protected, and who has authority over cultural practices. So integration strengthens healing rather than causing harm. So together, these steps help crisis systems reduce re-crisis risk, improve engagement, and build trust while staying grounded in both clinical best practice and tribal values. Next slide, please. And you can skip, I think, actually, to 2 slides. We'll pass it off to Jesslyn. Great. So now I'm going to turn it over to Dr. Jameson, James Klassen, and Rob Walker, and they will discuss the Certified Older Adult Peer Specialist Program.
Thank you so much, Taryn. I'm very excited to be here today. My name is Jesslyn, and I'm going to be sharing with you a little bit about the work we're doing at the University of Pennsylvania as part of our COPES program, which stands for Certified Older Adult Peer Specialists. And I want to orient you a little to kind of the rationale for this model and then talk a little bit more about the actual work. Next slide, please.
Jesslyn, could you please speak closer to the mic? It's harder to hear you.
Yes. How is this now?
A little bit closer, maybe,
Okay.
or louder.
Now?
Yes, that's better.
Okay. All right. Hopefully everyone can still see me. Okay. Thank you. So we want to start by acknowledging Dr. Zubritsky, who originally developed the COPES program along with the Pennsylvania Office of Mental Health Services and Substance Abuse Services, as well as the Pennsylvania Department of Aging. I also want to thank co-presenter Rob Walker from the Massachusetts Department of Health for his partnership in this work and all of his work to expand COPES in Massachusetts. And we're going to get to hear from him today more about that. I want to thank all the COPES who've gone through our training and our wonderful COPES team at UPenn, including Jim Klassen, who we will get to also hear from today. Next slide, please. We have no relationships or conflicts of interest related to the subject matter of this presentation. Next slide. So I want to start by orienting you to the peer specialist support landscape. So peer specialists are individuals with lived experience related to mental health needs paired with specific training to support other people. And this workforce goes by many different names across states. In Pennsylvania, some of our common peer support titles are certified peer specialist or certified recovery specialist. And really based on their lived experience and having walked in the shoes of the people they are supporting, peer specialists have a really unique set of skills which allows them to understand the experiences of other people, convey respect, and empower others to set goals and engage in recovery. And the importance of this work really has been recognized across the United States. Peer specialist support is reimbursable by Medicaid in most states. Next slide. So there's some promising research that shows that peer support can be very effective for a range of mental health conditions and presenting concerns. And very relevant to what we're talking about today, one study did show reduced rehospitalization and inpatient service needs associated with receiving peer specialist support. Because today we're talking about older adults, I just want to briefly touch on what we know about the research on peer support for this population. And I would sort of summarize it as we have some really nice emerging evidence for how peer support can really be important for older adults. And this is also just, we have less research than we do on the broader age range. But I will spend some time today kind of sharing about how sort of some of the data we collect from our program and also some of our reasons for thinking that this is really important, even as the research is still catching up. Next slide. So I want to orient you a little to the older adult population in the United States. And for the purpose of this, I'm defining that as folks who are 65 or older. And I know that might vary by different states or other people's definitions. So in the United States, we do have a rapidly growing older adult population. In 2020, an estimated 54 million Americans were 65 or older. 1 in 7 was an older adult, and that number had increased by 14 million from 2010. The number of older adults is projected to reach over 80 million by 2040. So these trends really indicate the importance of thinking creatively and outside the box on ways to meet the needs of this growing population. Next slide. As I think Taryn had on one of her slides, mental health needs do not discriminate. So older adults do have mental health needs, and there's been some research that these have become more pronounced since the pandemic. 1 in 5 adults 50 or older in the US experience a psychiatric disorder, which may include substance use disorder. And actual numbers may be even higher due to underreporting, due to factors like stigma, shame, but also limited access to providers who can make these kinds of diagnoses. There are also very important gaps in how older adults are able to access care. Only 1 in 8, approximately 1 in 8 older adults who reports feeling anxious and depressed also was able to seek professional help. And around a quarter of those with substance use disorder were able to seek help. And almost 20% of older adults do report that their mental health has declined since COVID-19. So we are at a very important moment to be thinking about how we might leverage models to support older adult mental health needs. Next slide. So there are several factors that may be associated with mental health concerns that also may be really responsive to interventions like peer specialist support. And I'm thinking really about factors like social isolation and loneliness. So as compared to non-older adults, older adults are disproportionately affected by experiences of social isolation and loneliness, which can happen for a range of different reasons, including that they're more likely to live alone, have physical health conditions that can make it difficult to be in community or leave the home and interact with others, and do often face the loss of family and friends over the course and as they age. Next slide, please. Echoing, I know, what was in a previous talk on this series, we know that social isolation and loneliness are very important because they increase the risk of a number of adverse outcomes, which can be things like dementia, coronary artery disease, stroke, depression, anxiety, and even suicide risk and death. In one study of heart failure patients, for example, loneliness was associated with nearly a 4 times increased risk of death, 78% increased risk of hospitalization, and 57% increased risk of ER visit. So these statistics really do underscore the importance of potential supports to increase connection and reduce isolation. Next slide. So this is where peer specialist support comes in. So not only do peer support work and peer specialists have the potential to bridge barriers to accessing care that older adults experience, this type of support may also be able to address some of the needs that really aren't typically addressed by traditional mental health service models. And interestingly, we've found in our work with the peer specialists that we train to become COPEs and the data that we collect during our work that peer support offers a very positive impact on the people who are doing the work. They really report that they find purpose, social engagement, and employment opportunities in their work as peer specialist providers. Next slide. So the COPES program is our Certified Older Adult Peer Specialist program, where we train peer specialists to and build on the training that they've received to really help them work as effectively as possible with older adults. And we really love the opportunity to train older adults to do this work. So there's some parallel lived experience. And we don't have specific age limitations or prevent folks who may not be considered older adults from getting trained to become a COPES. We have over 400 trained COPES across the United States in Pennsylvania, New Jersey, Massachusetts, Virginia, New Mexico, and North Carolina. And you're going to get to hear a little bit more about what this is looking like in Massachusetts and how some of these efforts have kind of taken off and have been really sustained at the state level. And COPES are really trained to support older adults in crisis support, community roles, and building up their own natural supports, advocating for themselves, self-help, self-improvement, and importantly, navigating the very complex healthcare and social services systems. Next slide. The goals of the COPES program are to prepare the peer specialist workforce to work very effectively with older adults with behavioral health needs, strengthen the workforce and their ability to meet the needs of those with mental health concerns and people who are aging and older adults, and overall improve quality of life for older adults. Next slide. So I want to share here some of the main topic areas that we discuss in a typical COPES training. And you'll see that this includes some topics that might be more generally applicable, things like motivational interviewing, trauma, anxiety, depression, but those that also apply more specifically to older adults, like cognitive change, elder abuse, family caregiving, older adult sexuality. But in any topic area we train on, we really try to focus on how that specific content really applies to older adults specifically. Next slide. So our COPES are key members of the healthcare workforce, working with and advocating for older adults who have mental health or behavioral health needs, and they can play very unique roles in bridging barriers to care and have a lot of knowledge that helps them spot mental health problems and make appropriate referrals. And currently our trained COPES really work in a wide variety of settings, which could include health clinics, hospitals, long-term care, senior centers, recovery organizations, or directly within senior housing. Next slide. So I know I sort of mentioned this bi-directional impact, or this idea that peer specialist support doesn't just impact someone receiving peer specialist support, but actually getting trained as a peer specialist can be a really powerful thing for someone. And we do collect some data from the peer specialists who are getting trained through our program. And on average, the people in our program rate the impact of importance as their work as a peer specialist as being extremely important to their own recovery and own mental health journey. Next slide. So instead of me kind of paraphrasing how people describe the ability to be a peer worker, I want to just share some quotes. One person shared, "It constantly gives me hope and gets me outside of myself. Providing peer support reinforces my own recovery, reminds me of my own progress, and builds my confidence and gives me purpose. Just the support of my peers and sharing our lived experiences makes me feel not alone in my recovery. I'm reminded of how far I've come, how much I overcame to get here, and how strong I am. I love helping people, so that builds my self-esteem and makes me happy." So just sort of, and this is not specific to being a COPES, right? But in general, sort of the power that is imparted by being able to channel one's lived experience into helping someone else. Next slide. So I want to talk a little bit about how peer support specialists and COPES specifically might fit into the crisis system. We think of COPES as being in a position to notice and respond to early signs of emotional and behavioral health crises. They really are equipped with an understanding of how these signs and symptoms may present in older adults and really the interplay of mental health, aging, and health conditions. And then they're really in a position to directly intervene on suicide risk factors like loneliness and isolation through how they engage with individuals and the types of supports they provide, which really do differ from what we typically see within the typical mental health system. Next slide. When they notice changes in an individual or risk factors or concerning behaviors, they really know the information and are equipped with the skills and resources to connect older adults to the right support. They really know their crisis hotlines, their local crisis system, as well as the aging support system. They have the ability to actually kind of support these warm handoffs and not just leave someone to self-present, but actually support someone in actually showing up, and can use skills and have refreshers on skills that are often covered in a typical peer specialist training, but are augmented through our COPES training to use things like motivational interviewing to kind of gain readiness for change. And very, very importantly, they have the ability to normalize an experience that can be incredibly isolating and scary for people, which in turn may impact someone's willingness to take these next steps and receive the support that they may need. Next slide, sorry. So in thinking about how COPES are embedded in the crisis response system, we can think of various roles. One, I think about, walking alongside someone, supporting warm handoffs, supporting that kind of continuum from crisis care all the way to aftercare, and really being there in those moments where an individual may be likely to fall through the cracks. They can really support things as an individual stabilizes, like care plans, planning for next steps, etc. And on a systems level, they're in a unique position to support connections across the crisis and aging systems. They really can help older adults stay engaged in relevant services and bridge these gaps that can occur both due to physical changes and ability to access services, but also systemic barriers to accessing these services in both the aging and crisis system. Next slide. Finally, their lived experience paired with the in-depth knowledge that they have makes them an invaluable asset to our mental health and crisis system. They have experience in navigating mental health systems, things like Medicaid, aging systems, social service systems, which many of us on this call know are not easy to navigate. They can really build trust with older adults who might not find a mental health provider to be particularly trustworthy or may find that step difficult, at least at this time. And they really can serve as someone consistent and really non-clinical who can stay involved in a way that often mental health providers or in our more traditional mental health models are not able to. And now I get to turn it over to Rob, who's going to share more about state level expansion of COPES training and programming in the state of Massachusetts.
Thanks, Jesselyn. I wanted to give a little bit of a introduction on how COPES came to be in Massachusetts and the future of it. So I'm an older adult. As I like to tell people, I've gone from acid rock to acid reflux, and I'm also a peer specialist. So in 2016, the Department of Mental Health really identified that certified older adult peer specialists could improve outcomes for older adults. Back then, we started with peers for transition age youth, so for people who aren't quite adults yet, and we were integrating peers in our services for regular adults, I guess. But I said, well, what if we expanded this to older adults? So we have a collaboration with the Mental Health Authority, which is the Department of Mental Health, along with the State Unit on Aging, which is now called the Executive Office of Aging and Independence. And we collaborated with the state Medicaid authority, specifically the long-term services and support folks, to see really how we could get this paid for, how we could finance using older adult peer support in our service delivery system. So what we came up with was adding COPE, Certified Older Adult Peer Support, to the Medicaid home and community-based frail elder waiver. So for those who don't know, the frail elder waiver is an extra series of services funded through Medicaid for older adults to keep them in their homes and keep them out of nursing homes. So it's extra services so older adults can stay in their homes. And that the waiver happened to be up for renewal at the same time we were thinking about all of this. So we added hours of COPES into the frail elder waiver as a funded service. And in a minute, I'll show you how those go about happening. But we had I would say I should update this slide now. We have probably about 300 certified older adult peer specialists in the past decade. Some work for older adults through this home and community-based frail elder waiver, and some work for our regular public mental health system, because we're seeing more and more older adults in our public mental health system. And they're really working across Massachusetts. So let's go to the next slide, please. So the way we do this in Massachusetts is that first the older adult has to go through the certification, the qualification process to make sure the older adult is authorized for waiver services. So they apply to Medicaid. A home care agency case manager can help them with the application process. And they get a case manager that can contract with the services that the individual need. So in Massachusetts, the older adult peer specialist services are delivered by external partner agencies. The home care agency doesn't have those services internally. They're funded through Medicaid. The COPES training has been through the Department of Mental Health only because we have experience training transition age youth peers, training regular peer specialists. So we decided that the Department of Mental Health was the best agency to oversee the older adult peer training. We also recently, Boston College School of Social Work, through their aging program, received a grant from the City of Boston Aging Services to train older adult peer specialists. So what we did with BC School of Social Work is come up with a self-paced program to train older adult peer specialists that Boston College could administer. So right now, I think as we speak, they're going through a trial of the program to gather data and see what we need. So that should be available in the future. And the oversight of the program is through a couple agencies, through the State Agency on Aging, through the Department of Mental Health, and also oversight through Mass Health, our Medicaid agency. So during COVID-19, there was a lot of older adults that really weren't receiving services because of COVID-19, because of all the other things going on. So we partnered with Karen Fortuna from Dartmouth. So Karen and I created a program called SOAR, Serving Older Adults Remotely. That was really a virtual peer support model for older adults. So we taught old peer specialists how to serve older adults in the home via Zoom, via FaceTime, or if the older adult chooses, just via regular telephone. So we've had a lot of success with that, and we're continuing doing remote peer support, especially during the winter. So most of the services that are available face to face in Massachusetts are also available remotely because of Medicaid and because of some Massachusetts legislation, and which is really serves older adults well, especially in the winter when the ice hazards, the snow hazards. So we've had quite the success with using the remote program. And we're also investigating using this program to support Alzheimer caregivers. So what we know as crisis clinicians that people who are caregivers also are subject to higher rates of depression, higher rates of suicide, higher rates of emotional crisis. So one of the things that we teach our older adult peer specialists to do is to support the family caregivers as well as the older adult in the home. So we're looking to figure out how to expand that program for caregivers. And one other quick thing, we've also had great success using this peer model, using COPES, supporting older adults around hoarding disorder. That hoarding disorder is a very labor intensive, I should say, costly to serve kind of issue with older adults, that it takes a lot of time, a lot of physical resources, and there's a lot on some traditional caregivers, a lot of frustration. But we've really found the peer-to-peer model with hoarding and older adults works very well. So hopefully we'll see more of that. So I'd like to pass it on to Jim, if we can do the next slide, who's going to talk about his own personal experience being a COPES.
Well, thank you, Rob, and thank you, Jess, too, and Taryn, everyone. I just I'll introduce myself, but I was really struck by I'm learning as we go too. Just struck by the statistics, just that Jesslyn, that you shared on where we'll be by 2040. Just sheer volume of us older adults that are coming online. And I probably should have been aware, but wasn't as sensitive to during COVID and post-COVID. What was it, a 20% statistic that you said of folks just not feeling right and probably still reeling from that. And Rob just brought up the caregiver issue, which we hear a lot in our training. But my name is Jim Klassen, and I am an older adult. In fact, I just turned 77 2 days ago. I'm an older adult with what we euphemistically like to call lived experience, mental health challenges, substance use, substance abuse was really a presenting issue. And these things were something that I struggled with for a long time. So how did I come to COPES? Well, first of all, I had to come to peer support, which I didn't know there was such a thing. But back around 2011, a therapist that was working with me, thank God, introduced me to WRAP, Wellness Recovery Action Plan, if anyone's heard of that. And that year, fortuitously, there was a WRAP Around the World conference, I think the first one that Mary Ellen Copeland held in Philadelphia. And there I met folks that were doing certified peer specialists. They said, you should become a CPS. I said, what's a CPS? Anyway, I became a CPS that year and have done some direct service, but mostly I've been a facilitator. I've been training for the last 14 years peer specialists in Pennsylvania and COPES for a shorter time, probably around 10, 12 years in the states that Jesselyn mentioned before. So I came to COPES kind of, through wellness, right, which I love that word wellness, not as opposed to recovery, but wellness journey. Also have physical issues with heart and hearing, myself. So it was sort of a late bloomer to all of this. So I have the impact on me professionally and personally has been incredible. I would like to give a shout out to SAMHSA, actually, because we use in peer support training and COPES, we lean so much on those toolkits that SAMHSA provides and the 9 recovery values and core competencies of peer support. So very important. But yes, COPES has impacted me personally, deepens my own recovery, my own self-awareness and reflection. I think of a connection is a big word for me, and I think of Dr. Gabor Mate and when he makes a statement that the opposite of addiction is connection. And connection has been such a huge part professionally, I guess, and certainly personally in this work. I say professionally because it is personal. It's all personal to me. So the connections with Jesslyn and my the rest of the crew at UPenn, and in my other work, and with the folks that almost on a weekly basis I'm working with that want to become peer specialists, right? And often ask about COPES. And so we hope to be able to provide that more and more. I guess this is the plug for COPES here, and we hope that that'll happen. So Yeah, the continuing joy and benefit has been facilitating COPES. We've been down in North Carolina and Virginia, and we hear from the trainees about they're already providing, well, they're already peer support staff, or they wouldn't be in COPES. But a lot of times what we're hearing about is sure what they're encountering in their work, and I'm sure, Rob, this is true of you, in their family, in their neighbors, in their community. And I was so reassured to hear, Taryn, when you referenced before the neighborhood connection, the mutual aid. I think we're going to be relying on that so much more and more and more. Um, and those connections continue, right? Jess, we hear all the time from folks that we have trained as COPEs, what their experiences have been out there, sometimes with a question, sometimes with a story. I'd also want to plug, I don't know if it's been mentioned, maybe it has, just the intergenerational aspects of this work, which I think can be incredibly powerful. Intergenerational, interfaith, inner no faith, but inner, right? Just folks across the whole spectrum, all of the spectrums, working and supporting together. Um, yeah. So, yeah, I don't know. What else should I say? Jess, what did I miss?
Yeah,
Jess.
no, you hit
Oh,
everything.
I know. You want me to talk about the systems. Well, I think we already have, right?
I think you hit most of it, and I think we can probably because we want to make sure we have time for questions so we can hear more from the audience. So if
Exactly.
we want to go to the next slide, we can just quickly wrap up and leave as much time as we can for questions. Thank you so much, Jim and Rob. So we've shared a little bit about what COPES looks like in various states, what it is, how it impacts the people who do it or even run as trainers. So if this is something that could be interesting for your system, please feel free to reach out to us. Something we do like to know, because sometimes we'll get requests from people who want like one person to be trained, and typically we work with systems. I think after hearing from Rob, you can probably understand a little bit more why we want to like build a network. So please feel free to reach out. We would love to hear from you. And I think I'm ready for the next slide, which is references. And then we'll go back to Taryn and hopefully we can move into Q&A. Thank you everyone so much for your time.
Yes, thank you so much, everyone. It's a great reminder about why I got started in the LTSS field because I just really love it. I love everyone that works in it. It's very inspirational. So thanks for all this information.